and let's get started. I am super charged up to have one of my favorite individuals and guest panelists who has been on a few of these webinars since we started, Dr. Alex Mohseni. And Dr. Alex is really a special doctor, in my opinion. He's an entrepreneur, he's an innovator, and his skill set goes way beyond being a board certified emergency room physician. In fact, we're working on a digital project together, and it's quite amazing. His ability to navigate tech and go beyond what I would think a doctor's primary skill set is. So first off, Alex, thanks so much for, here, let me unmute you, or I guess, yes, okay. Let's unmute yourself there, Alex.
Got it. Okay. Can you hear me?
So,
after all those accolades about technology prowess.
Yeah. So it always blows my mind where you have sort of like a tech person, and then all of a sudden their Zoom meeting just goes haywire. But anyways, Alex, I really want to get into your program. You laid out a great platform for us, but before we do it, I don't like reading people's bios. I like kind of having a conversation. Just for the audience, tell us a little bit about your career and your background, and
sure.
Then we can kind of lead in to your new project and what you're involved with.
Awesome. Thank you, Steve, and thank you for creating this community where we can all learn from each other. So I'm an emergency medicine physician by training. I've worked in many of the local ERs, including Sibley, Virginia Hospital Center, Reston, and others. And I was the Chief Innovation Officer for Emergency Medicine Associates for a number of years, and I built out the telemedicine division of our practice, which included a large-scale telemedicine program for 200,000 Medicaid members on a value-based care model as opposed to fee-for-service model. And after that, I joined a telemedicine company called SiriusMD and helped them grow into a national program. And I continue to do shifts on the SiriusMD platform. But now in this era of the the COVID-19 emergency era, I saw that there was a niche that was unfilled, which was providing a virtual clinic solution for Medicare seniors, many of whom were having difficulty or have been having difficulty reaching their usual sources of care. And that's kind of what I wanted to talk about today.
Awesome.
Yep.
Now, just I know it's on your bio, but where did you go to college and med school?
Yeah, so college, University of Maryland in College Park, then med school at Maryland in Baltimore. I did my residency at Jefferson in Philadelphia.
Okay, great. So you're a Mid-Atlantic provider, and most of the people that are on this call are from the Mid-Atlantic. So great. Well, what I'm going to do, Alex, just so that we have maximum screen for you, is I'm going to drop off visually, and then as I'm going to say to the audience as I drop off, if something comes up, type in a question as it comes to you, and we want to make sure that we address the questions. Try to keep your questions in Q&A and not in the comments box. It's hard for me to keep track of those to address them. And then the other way that you can ask a question is by raising your hand. So with that, I'm dropping off the screen, but you'll either hear my voice or you'll hear me pop back on again if something comes up. But take it away, Alex. And
awesome.
I know you know how all this works.
Awesome. Thank you, Steve. And just to confirm, you're able to see my screen?
Yep.
Okay, great. So let's go. So yeah, so this is my background. I'm also the medical director of a remote patient monitoring company, and also the co-host of the Mastering Medicare podcast with Dr. Amy Schiffman, where we explore all the nooks and crannies of healthcare. So so today's topic is the idea of urgent care and virtual clinics and where they fit in the spectrum of care. So I just wanted to kind of highlight briefly the common types of care that many of the seniors whom we serve can tap into. On the left, obviously, is primary care, which is mostly a longitudinal, relationship-based type of healthcare. It's typically scheduled. It's focused on chronic diseases. Oftentimes, primary care has limited after-hours capability, limited interventions that can be done in the brick-and-mortar space, and limited diagnostics. On the right end of the spectrum is emergency care, which is episodic, unscheduled, designed for acute care as opposed to chronic care, always open, extensive interventions and extensive diagnostics available. What I didn't include here is that it's also extremely expensive. And in between is this urgent care notion, which I'm learning as I interact with more seniors is somewhat of a foreign concept for many seniors. It's not something that they really grew up with. Many younger folks get a majority of their care in urgent care, but that's not necessarily the case with the seniors whom we serve. So urgent care tends to be episodic, unscheduled, a mix of acute and basic primary care, kind of depending on the type of urgent care. They tend to have extended after-hours capabilities. They tend to have more interventional capabilities than primary care doctors, more on-site diagnostics. But the scope of practice of urgent care is highly dependent on the resources and the skill set of that specific provider and the facility. So I think one thing that's really important if you're a senior serving professional is to get to know the different types of urgent care and freestanding ERs in your area, what resources they have, and what they feel comfortable doing. It used to be that urgent cares were these kind of small mom and pop shops, but now there's relatively large ones that are kind of like mini ERs. You see them as Patient First and some of the other kind of name brand ones out there on Rockville Pike and elsewhere. So they're growing in scope of capabilities and skill set. And as you can imagine, there's a lot of gray zone in between these three types of care. And we're going to talk a little bit about that today. So what are some of the differences between urgent care and ER? I want to highlight them here. So let's start with diagnostics, advanced diagnostics like CT scan, MRI, and ultrasound. The ER obviously has access to all of those, typically 24/7. Urgent care very generally does not have any of those, although ultrasound is growing as a radiology modality that's available in some of them, but it's highly dependent on the skill set of the providers there. EKGs can be done by both types of venues. X-ray can be done by both. However, X-ray is, there is a difference in an X-ray being done at an urgent care versus ER in that very often in the ER, you may have the in-house radiologist who could be technically from home giving an official report relatively quickly right after the X-ray, whereas in urgent care, oftentimes you're getting what we colloquially call a wet read, so a preliminary read from the urgent care doctor, and then the radiology official read might not happen until the next day. And there's a reason radiologists go to school for at least 5 years. There's a lot of nuance to reading radiology films, and sometimes that can be missed by the urgent care doctor. But I'll also add, on the other hand, there are many ERs where the ER doctor is the one giving the preliminary read, and it's a similar situation to urgent care where The radiologist might not give the official read until the next day. So that's something that you should know about. Next, on the lab front, obviously the ER has access to almost every lab you can imagine because they're connected to the hospital system. But urgent care is oftentimes much more limited in what sort of labs they can run. And many more tests are probably going to be send-outs there. Both types of facilities can do IV fluids. Sedation is something that is typically not done in urgent care. So if you have a bad injury that requires a reduction, so let's say the bone fragments are out of place and you got to put them back in, or you have a significant large wound that is extremely painful, the patient might benefit from having what we call moderate sedation or conscious sedation, where we're kind of like putting them to sleep in order to be able to tolerate the procedure. That sedation is something that can be done in pretty much every ER, but is generally not done in urgent care. Next is advanced airway techniques. So if you have an acute emergency where somebody's airway could be at risk, the urgent care is absolutely not the place to send them. And the ER is a better place for that. On the medication side, the scope of medications that can be administered, especially IV or intramuscularly at the urgent care, is going to be more limited. They're typically going to have the basic things, some of the most common antibiotics, for example, nausea medication, etc. ER is going to have much more capability there. This seems obvious, but some people don't know it. You know, if you have a very sick patient who could crash and need life support in terms of being mechanically ventilated or be on pressors or anything like that, again, the urgent care is not the place to send them. And then the last point on this slide is access to specialists. You know, a lot of times the ER doctor doesn't know what's going on and they need to tap into a network of specialists to get some advice. That's really easy in the emergency room because you have an on-call list of specialists who have the responsibility of responding to those requests. But the urgent care might not have that and typically has a limited access to on-demand specialist consultations. So I'll pause there for a second just to see if there's any questions. Doesn't look like it. Okay, I will continue. So what I just reviewed, most of you already know, but I think where it starts to get more interesting is, you know, one of the things that I really care about is how does the patient know or the caregiver know whether they need the emergency room or whether their issue is better taken care of at an urgent care or can wait totally safely for their primary care doctor.
Hey,
and
Alex?
yeah. Yep.
Yeah, I don't know if you want to, I don't want to interrupt you, but when you asked about questions, a hand went up. Beverly might have a question here.
Yeah, sure.
Beverly?
Hi,
Beverly?
yes. I'm a strategic planning futurist, and I'm wondering if you could just mention quickly how you see urgent care taking on more of the ER if, I mean, for example, access to specialists, you should be able to get that in urgent care if you need it by video, I mean by digital, like what we're doing now. And it's not as good as the person in the room, but it's a lot quicker, and urgent care may be a lot closer to the person than the ER is.
Beverly, I couldn't agree more. So when something doesn't make sense, the answer is typically money. There's a few other explanations, but money is the most common one, I would say. So you have to think about, to answer your question, you have to think about why do specialists take call at a hospital? There are several reasons. One is that they have to take call because that's part of their responsibilities and requirements in order to be able to be credentialed at that hospital and operate at that hospital. So for many physicians, it's an obligation at the hospital, and it's not necessarily an obligation that they want. On the other hand, some physicians and some specialties want these consults because it's a source of new patients for them. So, it's a really complicated issue. Without a doubt, there's no technical roadblock. You're right. The specialist could get on a phone call or a video the same as they could for the ER. It's really all the politics and money issues that, and I guess some of the clout of the urgent care to be able to reach out to a network and say, do you mind if we bother you at 2 a.m. with new cases? And many specialists will say, sorry, that's it's not something I want. But great question. So as I was saying, one of the things that I'm really interested in is helping people figure out whether they need the ER or not, because I see two common errors, both of which have a major negative impact. One of them is that too many people use the ER when they don't need it, which wastes a lot of money and resources. It wastes their time. It reduces the capacity of the ER to take care of the people who really need them. And on the other end of the spectrum are people who really should be going to the ER, but are not. They don't recognize that what they have is potentially extremely dangerous. And that error is, I would say, has even more potential negative consequences when we're dealing with seniors. And we're going to talk about some of these concepts. So the way an ER doctor thinks is that when they are presented with a chief complaint, call it chest pain, abdominal pain, lightheadedness, nausea, vomiting, the algorithm that we go through is we start with a list, what we call the differential diagnosis of what are the potential most dangerous things that could be going on, and what am I going to do in terms of taking a history, an exam, and vital signs and testing in order to eliminate those or identify them as being highly unlikely. So we start from the perspective of what's potentially most dangerous, even though it might not be the most likely. And I point that out because it's a little bit different from the typical perspective of a primary care doctor, where a common phrase is in medicine is that common things are common. And so it's kind of a special, unique perspective that ER doctors have. It does lead to a lot of over-testing and higher expenses because we're worried about the dangerous things because we see a disproportionate number of dangerous things. But I just want to kind of share that perspective. So when you look at these symptoms that I'm listing here, chest pain, shortness of breath, abdominal pain, new neurologic symptoms such as altered speech, ambulation, vision, or strength, any sign or symptom of sepsis or a severe infection, these are symptoms that could be life or limb threatening. Could be is the operative phrase there. And it's very difficult with something like chest pain, especially in a senior, to get enough history and exam from a virtual platform where you're just talking to them and be sufficiently able to eliminate all of the potentially dangerous causes and say, you don't really need to go get checked out. You can wait a day or two to see your primary care doctor. So there's certain chief complaints that are highly likely to send a senior to the emergency room. And I'm going to finish off the list here. So any sort of heavy bleeding, medical conditions that are sudden or severe. Sudden things tend to be very dangerous. So any sort of sudden neurologic symptom, sudden chest pain or shortness of breath, these things tend to signify often a cardiovascular issue or other dangerous thing. Any senior who's feeling weak, dizzy, or lightheaded is extremely difficult workup to try to figure out whether that is something dangerous or not, and oftentimes need vital signs and other kind of in-person touch points in order to figure out. And certain fevers and infections absolutely can be very dangerous. So So those are kind of the obvious ones, right? If you have a 70-year-old with chest pain, almost always they're going to need to go to the ER to get checked out, unless it's something that they completely recognize as like their stable angina. Where things become really challenging is when you have a type of symptom that a layperson might not recognize could actually be caused by something very dangerous. And I want to list some of those for you because I think if you're a senior serving professional, you're going to occasionally interact with a senior who might have kind of one of these symptoms or vague symptom, and you might be thinking to yourself, I wonder if this is something potentially dangerous, and how would I even know that? Is this something that might need to go to the emergency room? And again, how are we going to figure that out? So, for example, headache. Here are some causes of headache that are actually potentially dangerous. Acute angle closure glaucoma, which is really an eye issue but can present with headache symptoms. Temporal arteritis, which is inflammation of an important artery that, if missed, can lead to blindness very quickly. Bleeding in the brain, which is more common in the elderly because their brain has shrunken as they age, but the skull has not. So there's more tension on the vasculature of the brain. Meningitis can present in multiple different ways and can present in kind of a easier to miss way in seniors. Carbon monoxide poisoning, especially in the wintertime, can present with headache. Back pain can be the presenting symptom for aortic dissection, which if you guys remember Three's Company, John Ritter, I think that was his name, right? That's what he died of. Aortic dissection is one of the silent killers that's really hard to pick up. A spinal cord abscess, which, if there's a history of IV drug use or diabetics or other untreated infection, can be a very dangerous cause of back pain. Or cauda equina, which is an acute neurologic emergency that can have multiple different causes and kind of tricky presentations. Nausea and weakness, very commonly can be just a little bit of a stomach upset, but it also could be something life-threatening like aortic dissection or aortic aneurysm, or it could be from a cardiac ischemia, so poor blood flow to the heart. If you have somebody with a cold or pale limb, that can be a blood clot in the artery of that limb. Somebody with a swollen calf could have a blood clot in the leg, which can then transmit up to the lungs and cause what we call a pulmonary embolism, a blood clot in the lung. And for pulmonary embolisms, the presenting symptom could be just a fast heart rate without a clear explanation, although typically they'll have some sort of chest pain or shortness of breath. That's not always the case. Dizziness in the elderly is extremely difficult to evaluate. It can be something as mild or as simple as mild dehydration. It could be an inner ear problem, but it can also be something life-threatening like a posterior circulation stroke or a complication of atrial fibrillation or some sort of cardiac arrhythmia. A dental pain, I'm sure you guys have heard stories where a simple mild dental infection, if left untreated, can progress to an abscess, which then can progress to very sensitive parts of the head and lead to severe infections, including things like meningitis. Certain rashes, many rashes can be totally benign, but some of them can be a sign of severe underlying medical condition like a low platelets, which can lead to dangerous bleeding. If a senior has new numbness or pain in the groin, it can be a sign of a serious soft tissue infection we call necrotizing fasciitis, especially if they're diabetic or otherwise immune compromised. And that's something that can kill somebody in a matter of hours. A simple cough, again, could be something as simple as a mild upper respiratory infection, or it can be a sign of congestive heart failure or arrhythmia. And my last example here is, if a red eye or a painful eye, it could be pink eye, but it also could be something like acute angle closure glaucoma, which is dangerous and can lead to blindness if not treated. So my point here is that there are many different types of presentations can be caused by a wide spectrum of either very mild, non-dangerous, relatively benign conditions, or potentially very dangerous conditions. And this is what I've experienced a lot in my career, which is that people don't recognize these necessarily. And this is one of my key messages today as to what, why did I create the medical practice that I created today, or not today, recently, because I have a lot of people who ask me for my virtual clinic that I've created for seniors, well, what can you really do? How much can you actually diagnose? And it's a great question. In terms of what you can completely diagnose and treat, you're right, the scope is limited. I'd say out of all the different conditions, it's maybe 10 or 20% of the conditions out there can I really, from beginning to end, manage and take care of completely. But one of the other major value propositions is that I can take all the time I need and ask a bunch of questions of you and even look at you through a video screen and help determine whether one of these dangerous causes is likely or not. And there are certain things that you might describe, or the senior might describe or point out, that would greatly increase our concern for a life-threatening issue. And it's something that a layperson or the senior themselves might not recognize, right? So one of the things we learn as physicians is that taking a great history is really critical to figuring out what's wrong. And that's something that you can do really well via telemedicine, via virtual platform, on the phone, on a video session with a patient. You can ask all the questions you want until you say, okay, I really don't think something dangerous is going on, or you know what? You have told me a few things that I'm really worried about, and I think you really need to go to the ER. And I think being able to do that is something that's truly valuable. I'm going to pause there for a second. There's a question from Jennifer Brown. There's a MedStar urgent care office in Adams Morgan where I live. Frequently, there's a DC ambulance transporting a patient from the urgent care to the ER. That patient likely wasted critical time. That's exactly right. So when you leave it up to the patient to figure out, or their family member, as to what's the right venue, is it urgent care or is it ER or primary care, a lot of times people are making an error, and going to the urgent care and then being redirected to the ER does or can waste critical time with certain conditions, and it adds cost, and nobody likes that.
Hey, Alex.
Yeah.
Another question from Karen Wolfram. What about obtaining past history, medical records in urgent care versus ER? It can be critical to get pertinent information quickly, especially if the senior does not have a competent advocate present.
Yeah, it's a great question. I would say that physicians everywhere, in all contexts, in all venues, have to deal with this issue. And thankfully, technology is starting to help us solve this problem. So in the state of Maryland, we have the CRISP Health Information Exchange, which is really helpful in terms of accessing recent hospital records. I myself use the Athena electronic medical record system, which makes it really easy for me to tap into the CRISP records and other records from the patient visits with other providers who use Athena. Many EMRs tap into the SureScripts prescription tool so that you can get their prescription history, which oftentimes is a very good signal as to what some of their pre-existing medical conditions are. For example, if you see somebody is on a Coumadin or another blood thinner, that's something that can pop up just from putting in their identifying information into the EMR. But yeah, that is a challenge that we all deal with. Great question. So one other topic I wanted to touch on is how are seniors more challenging with healthcare in general, but especially if they're having an acute medical issue. I want to touch on a few points here. Seniors don't necessarily present with the typical or classic symptoms of many conditions. As an example, many seniors might not have a high fever if they have sepsis. In fact, they might have a low temperature. Seniors often are on many different medications, and those medications can mask some of their symptoms. For example, if you are on a beta blocker for blood pressure or another heart rate, heart condition, that might mask an elevated heart rate that you might typically have with an acute dangerous condition. They have limited functional reserve. So what that means is if they do start declining medically, the ability of their body to respond quickly enough and properly enough to the kind of insult to their body is limited. Communication with the elderly can be challenging if they're hard of hearing, or maybe they don't have teeth, or there might be dementia. All of these can make it really difficult to get a really good history. And if you can't get a really good history, everything downstream is much more difficult. Some seniors don't manifest pain the same way that younger folks do. And especially when dealing with the World War II generation, a lot of them may be more stoic and might not be as open about reporting some of the symptoms and pain and discomfort that they have. So definitely when dealing with seniors, we need to be more thoughtful, more cautious, and more keen to kind of pick up on little cues. So we have a few more questions here. Do you know anything about, or can you comment on the fact that we are being told for estate planning, medical care, advanced directive planning, especially since caregivers cannot go to hospital with the person, they are saying we should consider the coronavirus advanced directive addendum. I'm trying to read the question.
Yeah, it's a long question. Yeah, a good one.
Sorry, I'm having trouble figuring out what the actual question is, but maybe you could rephrase it in a shorter sentence. I'll go to the next one.
Or it might even be, maybe even just rate. I know the person is anonymous, but they could raise their hand and verbally ask it. I think the one below that is kind of interesting, talking about sensors.
Yeah, Susan Schiffman says, what sensors could be developed that elderly could have in their homes that would help your diagnosis? Amy Schiffman's mother. Fantastic. Hi, Susan. So yeah, so there are many sensors available out there, and I myself am the medical director of a remote patient monitoring company. So we, there's a lot of sensors in terms of tracking patients' blood pressure, heart rate, respiratory rate, oxygen level, glucose, weight. All of these can be monitored. And what's really great now is that Medicare will reimburse for monitoring of these vital signs as long as it's done in the right way, where the data feeds back directly to the ordering physician or provider. It's a great program that really increases the touch points. We call it remote patient monitoring. Some people call it telemonitoring. If anybody has any questions about that, connect with me offline. Happy to discuss that with you. So what sorts of conditions can be managed by phone or video? As I mentioned earlier, when taking care of anybody by virtual care, and the ER mentality is even in person, the first order of business is to make sure that the person doesn't have an acute emergency that they would need to be directed to a higher level of care for. So a lot of times the first questions after introducing yourself may be focused on just making sure that an acute emergency doesn't exist, and then going on to more details after that. But as I said earlier, there's a lot of conditions that we can manage after determining that there isn't an acute emergency or unlikely to be. And these include minor illnesses, colds and cough, fever without signs of sepsis, minor injuries and sprains, certain types of sore throats and sinus infections, uncomplicated urinary tract infection. I want to pause there actually for urinary tract infection. It's such a common thing, especially in seniors. So if a urinary tract infection is isolated to the bladder, seniors will typically have, but not always, some mix of burning, frequency, urgency. And as long as they don't necessarily have symptoms that would suggest that the bladder infection has spread up to the kidneys or to the blood, then that sort of urinary tract infection can be treated with oral antibiotics on a short regimen, typically 3 to 5 days, with a relatively high resolution rate. But keep in mind that there is no antibiotic that will work all of the time. In an ideal scenario, you would get a urinalysis and a culture. A culture means you send the urine samples to be grown to see what bacteria grow out and what those bacteria are sensitive to. You know, what we see a lot out there is that there's increasing resistance to many forms of antibiotics. And so we're getting higher failure rates. And so UTIs can be particularly dangerous because very often they can be caused by what we call gram-negative organisms, which can, the infection can then spread to the kidneys and blood. And when they enter the blood, they can cause sepsis, and people can lose their limbs. People can die from sepsis. So a UTI can span the spectrum from very easy to treat to life-threatening, especially if it goes untreated or if the treatment fails. So even if a senior is being treated for UTI, you do want to make sure it's resolving completely and they haven't developed resistance to the antibiotic, because if they have, then they may need to be switched to another antibiotic or may need IV antibiotics or more. Certain rashes are easy to diagnose online and can be managed. Pink eye, which again, as I mentioned, if it's true, just plain, viral conjunctivitis, easy to treat. But especially with folks above the age of 50, we have to be more careful to make sure other potential diagnoses are not causing the redness in the eye. Minor exacerbations of asthma and COPD can be managed relatively easily through phone and video. And uncomplicated blood pressure and blood sugar abnormalities also. These are just some basic examples. Donna Blackwell asks, what is your feeling about doing capacity appointments via telehealth, an in-depth exam for competency? I think depending on the ability to get a good video connection, being able to spend time and ask all the questions that you need to, I think it is something that can be done through a video platform. From the technical perspective, I actually don't know all the rules about whether there's any special rules or restrictions on that. That'd be great if an elder care attorney could clarify that. But from a technical and a medical perspective, I don't see why not. Great question. And as we mentioned before, what if it's something that you can't diagnose by phone? What if it's not something minor? Again, I think there's a lot of value that can be provided by listening to all the history, asking very specific focused questions, and helping distinguish whether the medical issue is safe to wait for the primary care doctor or whether the patient should go into the ER versus urgent care. And I want to share an example of the types of examination tricks we can do via telemedicine. I've been practicing telemedicine for more than 4 years now. And I'll just share a story. I had a gentleman who came on to my platform about a week ago, and he presented with abdominal pain that he thought was constipation. And his discomfort happened to be localized to the right lower quadrant, which is where the appendix is. And what I had him do, well, I'll pause for a second. I'll say, one of the clues that you may have appendicitis is something we call peritonitis, so inflammation of the lining inside of the abdomen around the bowel. And so I had him stand up and try to hop up and down. And if somebody has inflammation of their peritoneum from something like appendicitis, they're typically not going to be able to hop up and down because it just hurts too much. And that's exactly what was the case with this guy. And so he had a very good abdominal examination for appendicitis, all done virtually over phone and video. And I recommended that he go to the ER to be evaluated. And I got a call from him later that day that he went to the ER and he did have appendicitis. They operated on him, took it out immediately. And because of COVID, they discharged him the same day, which, is kind of a slightly new thing. We used to at least watch them overnight pre-COVID, I would say. So there's a lot of little tricks that can be done, and certain exam elements that you might not think of, can be done virtually. What if the patient can't use a smartphone? Thankfully, Medicare has relaxed the rules They've understood that not all seniors necessarily have video capability. And CMS has said that from their perspective, certain types of encounters can be done completely by audio without video, and that the provider should just document that the patient was not able to do a video. Keep in mind, though, that in addition to federal rules and regulations, there are also state rules, and sometimes the state rules trump the federal rules. And so just because Medicare says it can be done doesn't necessarily mean in your state it can be, without potentially putting the provider's license in jeopardy. I have a link here to the Maryland rules. Maryland has relaxed the rules as well. All of these rules can be a bit tricky to navigate, and they tend to be changing almost by the week. So keep that in mind. There's a question here from Tejash Natali. It says, hello, doctor. Are you currently using a tool to manage your telemedicine patients? If yes, what tool are you using? Is it an app for the patients? So I use Athena Health as my electronic medical record system. That's a great question. But I use a platform for the HIPAA compliant video and audio called DoxyMe. So you can go to DOXY.me, that's M as in Mary, DoxyMe. DoxyMe is one of the fastest growing telemedicine platforms. And I chose this tool because I think it's one of the easiest platforms to use. There's a free version. What's really important to me is that the platform be very easy for the patient. And what I love about DoxyMe is that when a patient tries to access the system for their video session with me, they don't need to have an account or a login or a password. And I love that. I think anytime you force the end user or the patient or family member to have to create an account and login and password, you're going to probably lose at least half of your patients right there. And especially in this emergency era, we really need to make access to care very easy for seniors. What about the primary care provider? I think this is a really important question. In the work I'm doing, I in no way want to supplant or replace the primary care doctor. I think primary care doctors play an incredibly important role, and I encourage all seniors to have a really close relationship with their primary care doctor. Now, unfortunately, some primary care doctors, either due to technical reasons or other issues, have had difficulty adapting their practice to a telemedicine program during the COVID-19 era. And some have been able to adapt but not provide sufficient number of appointments. Others have not adapted at all. And I've listed here some of the issues. There's technology challenges for the provider. There's technology challenges for the patient. Coordinating these sort of virtual appointments when your staff is at home and you're in a separate venue, that can be really challenging for some providers. And some providers are so confused by the billing rules that issue has really slowed them down. And the billing rules are very tricky for telemedicine. As you can imagine, there's certain rules that apply to Medicare, and each payer, each commercial payer has their own rules, and they say you have to bill it this way or bill it that way, otherwise you won't get paid. It's really not easy, and these rules are changing. So does insurance cover telemedicine encounters? Each payer has its own rules. Medicare has dramatically relaxed its restrictions. Pre-COVID, as a Medicare patient, you essentially could not get telemedicine from your home unless very rare situation if you were in a rural area, and even then you still had to go to like a clinic type environment to get access to telemedicine, which made no sense. But now, yes, Medicare is essentially covering most types of encounters via telemedicine. I have a link here. CMS actually publishes the exact codes that can be provided via telehealth. So I'm sure Steve can share this deck later and you guys can see that. Most telehealth services, like an office visit type thing that I would do, are a Part B service, so the patient still has their 20% responsibility, which might be covered by their by their secondary insurance. On the Medicaid side, many states have relaxed the rules and opened up the doors to coverage. But again, it's very state specific. Here I have a link to the Maryland rules about that. So my practice is called canarydoc.com, and that's spelled CANARYDOC.com. A lot of people ask me why I chose the word canary. It's because I really care about prevention, and this is kind of a little bit of a play on words on the canary in the gold mine as being the signal that something might be wrong. My phone number is listed here, 240-200-1442. Please reach out if you have any questions or issues. You're not sure if I might be able to help you. Just give me a call, and I'm happy to speak with folks. Again, I'm not here to replace any primary care doctor, but to augment if the primary care doctor is not available, and help folks out. So thank you, Steve, for giving us this opportunity. Giving me the opportunity to speak to everybody today.
And here, okay, we've got a more simplified question to the previous one. Can you comment on coronavirus advanced directives addendum in case you do not want to be put on a ventilator or life support, so you can say what kind of coronavirus healthcare person may want?
So that might be something. So I know we have MOLST and POST forms. I wasn't aware that there was a specific addendum for coronavirus.
One thing, and I don't know if this is touching on it, but one of the things, a year ago when you would go to an advanced medical directive presentation, the speaker or the attorney would always say, oh, if you don't want to be put on a ventilator, make sure that you put that in your advanced medical directives. And so I imagine a lot of us have that in our advanced medical directives, but the way the ventilators are being used to help somebody recover from coronavirus is a little bit different than what we kind of think about. Maybe we thought about a ventilator a year ago. I don't know if that touches on it.
Basically ventilators are used when you are not able to breathe well enough on your own to keep your oxygen level where it needs to be, or keep your carbon dioxide level where it needs to be. And early in the treatment of COVID-19, some of the data from Italy was suggesting that you should intubate people and put them on mechanical ventilation early to prevent them from crashing later. And I think that perspective has changed. And now people are realizing that many types of COVID-19 patients actually tolerate a high degree of hypoxia, of low oxygen, in a way that we really haven't seen in other conditions. But either way, certain people fail their attempts at breathing essentially without needing a ventilator and are placed on a ventilator. But once you're placed on a ventilator, I think it's the same issues from any condition that would lead you to be placed on a ventilator. Being placed on a ventilator is an extremely complicated, high risk thing. Many things can go wrong. You can puncture your lungs from high pressure, and that itself can kill you. And anybody who needs to go on a ventilator, that itself is a bad signal that you are much higher likelihood to die, regardless of the condition that caused it. So I'm not aware of specific coronavirus addenda, but feel free to reach out offline if there's additional questions on that.
Yeah, and also, you can email both Alex and I, and maybe we can connect you, bring an elder law attorney into the mix, and who can give some guidance in this area. Okay, so let's see. Okay, what I would say is that we're getting close to 1 o'clock. So this is your last call to ask a question. you can raise your hand or you can type it into Q&A. And while we're waiting for anything, potential questions, I have a little treat, new feature for these pro-aging meetings. I'm going to give something away. And, oh, here, I'm going to share my screen now. And what you should see on there is the Wheel of Fortune with everybody's name on it who registered. And let's see who's going to win. And it is Andrea Mathias. So let me write down that name. And if Andrea is in the audience, she's probably jumping out of her seat right now. And when she gets what I'm going to send to her, she's going to probably be disappointed. But you're a winner, Andrea. And I'll email you and make sure that I have your mailing address. So, well, didn't look like anybody raised their hand. Alex, make sure that you send me the slide deck. Send me any, oh, here, John Butterfield has a question. Can you recommend a buyer's guide to tablet computers addressing, among other things, clarity of audio and video, position, location of camera lens, which are poorly designed? Alex, do you have an experience with any specific tablet computer that you find works better than another?
Not really. I have found regular iPads and smartphones to be perfectly fine for what I've done.
And John, I have your email. I'm going to send you, how about we use, because we've had the folks from GrandPad and, oh gosh, the other company, it's based in Virginia, who I'm sure have done some serious investigation on tablets, and they might be able to give you some guidance. I'll shoot you an email this afternoon on this one. And actually, I mean, this in general could be a very good topic for a future discussion. Okay. All right, guys. So let's see. We are going to wrap things up. Again, we're going to give you the, I'm going to send you a link for the, whatchamacallit, the survey. I really want to get feedback so we can help design these webinars to meet your needs to the best of our ability. Also, I want to remind everybody that you'll have the choice now to have less frequent emails from us, because I know we're filling up your inbox. And so give us feedback in that area. But our next webinar, although there's tons of them on our event calendar, is scheduled for Tuesday. It's the Marketing Masterminds meeting. So I know it's not going to be appealing to everybody, but we are going to address the common phrase that we hear in senior living, I'm not ready yet. Oftentimes when people are looking into our services, even if they really need us, their first response is, I'm not ready yet, because we're selling all these aging related services and nobody wants to think of themselves as aging. So we're going to dive into that, and I hope that we come up with some creative solutions. So with that, thank you, Alex, and send your stuff over so I can share it with everybody. And we will see you guys next week. Have a great weekend.
Thanks. Bye-bye.